Thank you, Professor Nauck. I can't tell you how honored we are to have you as a chairperson. And as you know, Professor Nauck will be delivering a very important oration little later this evening. And he is the pioneer in the field of incretin-based therapy, one of the world leaders, one of the discoverers, innovators. And therefore, we're very, very privileged to have him with us to chair this particular session and also to give his oration a little later. Also like to thank Dr. Nigam for setting the stage for me to take over from where he left off. And after I finish, we have so many questions which have already come even before the talks are over. But continue to send the questions and we'll take as many as we can. So the title given to me is Redefining Weight Loss Goals, Comparing Tirzepatide with Semaglutide, which is something which a lot of people have already asked me. So these are my disclosures. I work with many companies, and this talk is of course supported by Lilly, and I'm contracted to speak for them. So let's start with a case study, and this is increasingly becoming common in our country, both men and women who are overweight. Obesity is very rapidly increasing, and you heard some of the ICMR INDIAB data yesterday, which Dr. Anjana presented from the whole country. And in fact, obesity is more in women overall compared to men. So here is Ms. Veena, 48 years old. Post-COVID, she has gained a lot of weight. And of course, this is a hypothetical scenario, but something which you commonly see in our patients. Body weight is 88 kilograms. Her BMI is 35.5. So clearly in the obese category. So she does not have diabetes. So she is obese and has dyslipidemia. She has tried lifestyle intervention few times, like many of us would have also tried. It's so easy to lose weight, but then it always finds me again, as we say. I lost the weight, but it finds me again and again it finds me. So that's what happens, and we know the mechanisms for that. We're not going to go into that. So every time she loses 5 to 6 kg, but probably regains not just 5 to 6, probably more than that. And that's a frustrating aspect about weight loss, and that's with lifestyle intervention, and which is why drugs like this are becoming very popular. Her father had diabetes, which means if she persists with this, given that she's of South Asian background, she's likely to get diabetes as well. No history of pancreatitis, no history of hypertension. She's just on rosuvastatin for her dyslipidemia. So activity of daily living, mildly impaired. She avoids stairs. 8 to 10 steps makes her breathless. So you can see it's a downhill course. So they keep trying and then they do less and less, and then it's a kind of vicious cycle. It keeps going. There's no history of pedal edema. Walking on flat ground is okay. Already stiffness in the left joint, so you can see where that's going. Osteoarthritis is already setting in. X-ray is already showing reduced joint space. So this is a kind of a thing which one leads to another, to another, to another, and then the problem gets worse and worse. So what do you do with Ms. Veena if you came to you? First thing, of course, we'll say take a very low calorie diet, aim for 5% weight loss. Look, we're only even aiming for 5% weight loss. We're not even expecting more than that. In the next 6 months, then we advise her to be on a 500 calorie restriction for baseline, and then say whether we can get a 10% weight loss. Then we start her on pharmacotherapy, and then if all else fails, we have good old bariatric surgery to think of in her case, uptake of which, by the way, at least in my city, is very poor. So, but then after discussing with all this, Veena comes up and says, but Doc, we heard about this new weight loss drugs. Do you think I should be trying it? Because I've tried all this diet and exercise for so long. Nothing seems to work. Do you think I should be trying this now? This is what everyone will be asking you now. Everybody's heard of these drugs now. So then they say, okay, should I take a GLP-1, or now I hear there's something else come, which is a GLP, GIP. Which one will you advise? Of course, there's no one answer, as you know, for these. So what evidence will you? So let's just look at the scientific evidence, and then we leave it to you and Mrs. Veena to decide which one to take. But then obesity doesn't come in isolation. Obesity comes with a lot of other baggage along with this. We already mentioned osteoarthritis, but it also comes with hypertension. She's already got dyslipidemia. CV outcomes are affected. then, and by weight loss, if you really reduce weight, what all can you improve? Well, you can reduce your hypertension, you can reduce your dyslipidemia, CV outcomes improve, diabetes prevention is possible, and then in some cases, if you lose enough, you have 10 to 15% weight loss, you can even get remission of diabetes. Whether it lasts too long, we don't know. Osteoarthritis can definitely be reduced. I've already started seeing patients who were advised to undergo knee replacement, and now after 2-3 months, the ortho has said, well, it doesn't look like you need it now. Your pain has gone, you're able to walk, you don't need. So these are all the additional benefits that one gets. Not approved for that condition, but these are additional byproducts that you get by weight loss. Sleep apnea. I don't have to tell you that OSA is such a common thing. And by weight loss, by any method, if you have your sleep apnea goes away. And of course, we talked about MASLD. Yesterday we heard the guru of MASLD, Dr. Arun Sanyal, talk to us about that, MASH, PCOS, and you can go on and on. Gestational diabetes to depression to so many things can improve with weight loss. So it's no longer a question of whether we should attempt for weight loss. It's only a question of how to address that and how much you will go and how aggressive you will go and how much benefit you can get. Now, Dr. Nigam has already talked about the two trials, the SURMOUNT trial, which is done in people without diabetes, and then we have the SURPASS trials, which are done predominantly in people with diabetes. SURMOUNT is mainly for the weight loss part of it. I'm not going to go into detail into this, but SURMOUNT 5 actually compared Tirzepatide with Semaglutide with respect to weight loss. It had 750 participants, 72-week trial. It's an open label trial. So let's look at SURMOUNT 5, which is a head-to-head trial looking at these molecules. One is a GLP-GIP, the other is just a plain GLP. And this is for people with obesity. So this is the trial design. So in one arm, they started with Tirzepatide 2.5, then went to 5, 7.5, 10, 12.5, and then reached the maximal dose of either 10 or 15, 15 being the maximum. And then in Semaglutide, as we start with 0.25, 0.51, 1.7, and then end with 1.7 or 2.4, 2.4 being the maximal tolerated dose. So it's a phase 3B, multicenter randomized parallel arm, open label active comparator trial. Primary endpoint is change in body weight from baseline to week 72. And this is what we find is that if you look at the percentage of body weight loss with Tirzepatide, there was a superior reduction in body weight because now you're addressing two hormones, GIP and GLP. So there was a 21.6% body weight reduction with Tirzepatide 10 to 15 milligrams compared to 15.4% in those who are taking Semaglutide 1.7 or 2.4 milligrams. Now, the next thing that is looked at is how many people achieved more than 25% mean reduction in their body weight. And as you can see, 36 points. So you're shown the data shows you 10%, more than 10%, 15%, 20%, and 25% weight loss. And irrespective of all those categories, whether it's more than 10, 15, 20, or 25, Tirzepatide seemed to have a greater reduction in mean body weight, in mean weight reduction. And if you look at the right-hand column there for you, more than 25%, 36.2% of patients in this trial achieved more than 25% of weight loss compared to about 20%, 19.4% in those on Semaglutide. So 1 in 5. Now, if you look at the waist circumference, similar results. There is a 20 centimeter weight reduction with Tirzepatide compared to about 15 centimeters weight reduction. This is 7.9 inches for those of you who think better in inches, about 8 inches weight reduction. I'd like you to focus on this for a moment. For those of you who know your pant size, okay, Now you minus 20 centimeters from that. You definitely will not fit into your old clothes. You definitely have to change your clothes. Okay? So that's a very significant, which is why these drugs, whether it is semaglutide or tirzepatide, I'm often asked, why did they take the world by storm? Literally, they've taken the world by storm. That's because till now we never had any drug which could even achieve this level of weight loss, let alone being safe and effective, because almost every drug until about 5-10 years ago would come and they would come and they would go within the first 2 or 3 years. Something will come, they'll be banned and they'll go. To an extent that we always thought that weight loss drugs are bad. They're going to produce some severe complication. This is what changed with these class of compounds. So the adverse effects are very similar in most of the trials. We know that they produce GI side effects because they do work on the GI system, but not significantly different between tirzepatide and semaglutide, except that one thing, that if you look at the injection site reactions, were slightly higher in the tirzepatide group, 8.6% compared to 0.3%. But for that, there was no significant difference between any of these side effects, and most of these were mild to moderate in the initial stages, and then as you continued them, they were able to tolerate, and most of them able to tolerate even higher doses of these drugs. They usually decreased over time. So they're predominantly gastrointestinal. No major side effects have come, and we'll discuss that later. Let me now switch to the second person whom I want to introduce, and this time Mr. Ajay, a male, 60 years old, slightly older, BMI is slightly lower, although the body weight is 92. Now this person does have diabetes. The other lady, Veena, did not have diabetes. He has diabetes type 2, 9 years, already has hypertension, dyslipidemia, no episodes of hypoglycemia, no history of pancreatitis. So the drugs he is on now is just metformin, 1500 milligrams per day. He's on EMPA, 10 milligrams once a day, and he's on his drugs for hypertension, amlodipine, telmisartan, and on rosuvastatin for his dyslipidemia. His last A1C is 9%. Is it good or bad? Okay. Nobody's going to accept 9%. Look at the blood sugars, 150 to 180, 200 to 260. So clearly, he's only 60 years old. He's not like 98 years old. So you definitely have to get his sugars under better control. He's also worried about his glycemic control and future risk of complications. Already, there's early cataract surgery, cataract changes. Luckily, there's no evidence of non-proliferative retinopathy or proliferative retinopathy or macular edema, but already neuropathy has started. So the first signs have already started of microvascular complications. So now what will you do with Ajay? Now again, there's no one answer to this. It depends on so many things that you have to take into account. The patient's acceptance, affordability, your own experience with it. So you can add many things. So because it's only on metformin, you can add sulfonylurea, EMPA also is there. So you can add basal insulin, you can try GLP-1, you can try GLP-GIP combination, you can add TZD. Now he's already overweight, remember. So if you're going to add TZD, basal insulin, sulfonylurea, it's likely that his weight is going to go up further. Okay. So you'd prefer, he's already on SGLT2. So if you really want them to lose weight, now we've got newer drugs. So you'll probably think of that. So you discuss with Ajay and he says, okay, now let's discuss this GLP-1 and GIP-GLP combination and what is the evidence regarding that. So we have these trials. So we have SURPASS 1, SURPASS 2, SURPASS 3, SURPASS 4 and SURPASS 5. And we'll just talk about SURPASS 2 because that is the focus of this discussion, comparing it with semaglutide. Remember, the first one was in overweight people without diabetes. Now the evidence is in people with diabetes. Now before that, just that we are all on the same page, we know that increased BMI is going to increase the prevalence of diabetes. And then the first question people ask is, why don't you just do it with lifestyle? Because it doesn't work. That's a simple thing. Look ahead trial, one of the largest trials which had been done, 5,000 people, a lot of effort went into trying to reduce weight and to control diabetes in those with diabetes and overweight. And people had BMI more than 25, and that's the age group. And they tried intensive lifestyle modification plus education, everything was tried. And we know that, yes, they did achieve initially a weight loss as well as a reduction in the weight circumference, but they soon regained their weight. The weight also regained, the weight circumference also increased. But in the group where they did have the weight loss, there was reduced A1C, excuse me, the blood pressure, fasting glucose, triglycerides, all improved. And then we also know that if you control diabetes better and reduce weight, the risk of CKD comes down. Neuropathy scores were also better. So it's not a completely negative trial. There were some improvements, but the problem is it comes back. Okay. So now let's look at the evidence of SURPASS-2, Tirzepatide versus Semaglutide. So here's the trial design. So we have one group which is treated with 5 milligram of Tirzepatide, one on 10, 15, and then we have the 1 milligram of Semaglutide, which is the comparator arm. And those are the starting 8.3% overall mean A1C, 8.6 years duration of diabetes, mean BMI is 34, 1,879 patients were enrolled. And here are the results. So as you can see, there was a 2.1% reduction in A1C with the 5 milligrams, 2.4% with 10, and 2.5% A1C reduction with 15 milligrams as compared to 1.9%, almost 2% reduction with the semaglutide 1 milligram. So it's interesting to note that even the 5 milligrams of tirzepatide was slightly better than the semaglutide 1 milligram. And here are the percentage of patients who achieved the A1C targets across all doses of semaglutide. And what you see here is HbA1c less than 7%, which at 15 milligrams, 92% of people achieved, 5 milligrams, 86% of people achieved that, and with semaglutide, 81%. If you make it even stricter, 6.5%, okay, that means almost going to a pre-diabetic value now. The values were 74%, 82%, 87%, and the comparator arm semaglutide is 66%. And now if you go to almost like a remission, it's not true remission because remission should be without drugs, but if you call it as normoglycemia, A1C less than 5.7. If you think of that, 5.6 or below, 29%, 45%, and 51% at different graded doses of tirzepatide achieved that as compared to 1 in 5, 20% with the semaglutide. Now, this is the weight reduction across the three groups. We first talked about A1C, and now we're talking about the weight reduction with the 15 milligrams, 12.4 kg weight reduction, with 5 milligrams, 7.8 kg, and with the semaglutide, 6.2 kg. Now, if you look at the composite endpoint, how many achieved A1C less than 6.5, plus a weight loss of more than 10%, plus no hypoglycemia, no severe hypoglycemia. So 3 endpoints. If you are able to look at that, how many achieved that? With 5 milligram tirzepatide, 32% achieved all the 3. With 10 milligram, 51%. With tirzepatide, 15 milligram, 60%. And with semaglutide, 1 milligram, 22% of individuals achieved that. Again, in this trial, looking at adverse effects, again, same story, that it's nausea, diarrhea, vomiting, dyspepsia. No serious side effects were noted, and no significant differences between the groups. Of course, at higher doses of tirzepatide, you do get higher nausea, diarrhea, and so on, but otherwise, no significant difference between the groups. What about hypoglycemia? The great thing about these drugs is that hypoglycemia is very rare with this group of drugs, and also with the SGLT2 group of drugs. One of the things is that, as Dr. Nigam said, it's glucose dependent insulin secretion. Therefore, when your glucose levels are low, it kind of adjusts. And so hypoglycemia is very, very rare with these agents, whichever one you use. And so to summarize, tirzepatide in the maximal daily doses demonstrated superior weight reduction compared to semaglutide in the maximal tolerated doses of 21.6% versus 15.4%. Superior A1C reduction with all 3 doses of tirzepatide compared to semaglutide, and the most common adverse reactions were gastrointestinal in nature and were mostly mild to moderate, and they went away after some time. So with that, I'd like to thank you And now we'll take questions. Thank you.